Welcome to this roundtable discussion titled Cardiothoracic Surgical Training Paradigms, Integrated versus Traditional and Everything in Between. Here at the 2015 Society of Thoracic Surgeons meeting here in San Diego, California. My name is Michael Bolaños, and I'm the United States resident editor for CTSNet and an integrated cardiothoracic surgery resident at the University of Kentucky. I have the honor of introducing our three panelists today, Dr. Richard Fines, Dr. Douglas Wood, and Dr. Asad Shah. Dr. Wood serves as a professor of surgery at the University of Washington in Seattle, where he is the chief of cardiothoracic surgery and an endowed chair in lung cancer research. He has helped pioneer the current lung cancer screening guidelines and is the chair of the National Comprehensive Cancer Network Lung Cancer Screening Panel. He's also the vice chair of the NCCN Non-Small Cell Lung Cancer Panel. As a strong advocate for thoracic surgical education, he has held positions as the past director of the American Board of Thoracic Surgery and past chair of the accreditation for a Council for Graduate Medical Education Thoracic Surgery Residency Review Committee. Dr. Wood has been the president of the Seattle Surgical Society, president of the Western Thoracic Surgical Association, and president of the Society of Thoracic Surgeons. Next, we have Dr. Fines. Dr. Fines is currently a professor of surgery in the Division of Cardiothoracic Surgery at the University of North Carolina, Chapel Hill. He is past chairman of the American Board of Thoracic Surgery and is best known for his pioneer work in establishing an integrated thoracic surgical curriculum and training paradigm. He is also on the forefront of simulation-based training for the advancement of modern surgical training, for which he has numerous publications. And last but not least, we have Dr. Asad Shah. He's a cardiothoracic surgery resident at Duke University. He is one of the first residents to be accepted into the 4+3 program that they have there and has an interest in pursuing adult cardiac surgery. He has numerous publications in various journals and currently sits on the executive committee for the Thoracic Surgery Residents Association and is a member of CTSNet Surgeons in Training and also serves as the chairman of the TSRA Education Committee. Thank you for joining us today, doctors. Let us first start our discussion about how the creation of an integrated pathway came to fruition. UNC Chapel Hill is one of the most mature programs in this training paradigm, and perhaps Dr. Fines can comment on the early days of the I-6 program and how it came about.
Thank you. The I-6 paradigm was really enabled by the work of Dr. Fred Crawford, who at the time was serving as the chair of the American Board of Thoracic Surgery, recognized the need to be able to train cardiothoracic surgeons without necessarily being tied to a 5-year general surgical curriculum. So the board enabled programs to transition or to change to integrated 6. There was also a 4-3 program in addition to the traditional program. We felt that the integrated program was a very good way to go. In our mind, general surgical training had progressively gotten further away from a lot of the skill sets that were necessary to be a cardiothoracic surgeon. That the total training time of 7 years, 5 of which were devoted to general surgery entirely out of our control, was potentially problematic. So we did start a program, and we'll be graduating our first resident this year. So that's been our history, and I will say that our experience has been outstanding. The applicants have been outstanding, and they have really, in my mind, driven the success of this program. And our first graduate is really an outstanding resident.
Great. And Dr. Wood, your program also has an integrated training pathway. Can you comment a little bit about your program and maybe its beginnings and how that came to fruition there?
Well, I agree with Dr. Fines. I think that the idea of an integrated program is a sound one, and one that there's many other models for in other specialty areas in surgery. So we were very enthusiastic about it as well as the UNC program was, and we're early adopters of integrated residency, and likewise the applicants to our integrated residency program have been spectacular. I just finished interviews of candidates for our integrated residency, and we're a year behind UNC. Our first graduate will be a year and a half from now. And our first graduate is a superstar. She's just terrific, and I think it's a very valid pathway into cardiothoracic surgery.
Great. And Dr. Shaw, maybe you can comment a little bit. We're throwing around a lot of terms here: integrated, 4+3, traditional. For those people that might be watching that aren't familiar with the three pathways, maybe you can elaborate a little bit about what each one means and how it's set up.
Well, the traditional pathway involves completing a general surgery residency, which is generally 5 to 7 years. Towards the end of that residency, you apply for a match into a traditional cardiothoracic surgery residency, which is typically 2 or 3 years. So the whole process would take anywhere from 7 to 10 years, and you would not start any cardiothoracic training till you were between 5, 6, and 7 years into your training. That's the old traditional way. The newer way is called the I-6 or integrated residency, in which residents match directly into cardiothoracic surgery right out of medical school. So most programs are 6 years, which some have a component of research of 1 or 2 years as well. And you start your cardiothoracic training right away from your first year all the way to your last. And then the in-between or middle way has a variety of terms. It's called often the 4-3 program or the coordinated program. And that involves completing part of a traditional general surgery program, most of the time about 3 years, then 2 years of about half cardiothoracic and half general surgery, and then your last 2 or 3 years being completely cardiothoracic. And in this middle scenario, you're still eligible to become board certified in both general surgery and cardiothoracic surgery. And this program usually involves staying in the same thoracic program in which you completed or were doing your general surgery training.
As we look into the future of the training, of future cardiothoracic surgeons, some larger institutions, I can think of Hopkins and others, have been slow to adopt the integrated pathway. Dr. Wood, you come from a place where you have integrated 4+3 and traditional, and so does Dr. Shaw. Maybe you can comment a little bit about why some of these programs have been slow to adopt the integrated training pathway, and what weaknesses you still foresee there.
Well, I think there can be many reasons, and every program might have its own, but I guess I would put them dominantly in a couple of categories. One is it's hard. It's not an easy thing to do. It requires a whole restructuring of a curriculum, of program organization. It requires approval in the local GME office for additional positions, which is very difficult to get these days. It requires a coordination with typically the general surgery program director of a coordinated aspect of training in the early part of the integrated program. And if that's not feasible, the development of a whole new set of possible core surgery rotations at nearby regional institutions. Sure. So all of those things are hard, and so it's not necessarily something that is a turnkey operation that somebody can do just because they want to. It takes a lot of effort, and there can be institutional barriers to that. But I think another reason, and one that is important, is it doesn't necessarily, the integrated programs I think are very good. It doesn't necessarily mean that they're better or that they replace the traditional pathway. And I think many still prefer the traditional pathway and may have purposefully chosen to keep a traditional route that is 5 years of general surgery with either the 2 or 3 year cardiothoracic training, because we have a history of it being very successful. Yeah, exactly. It's been very successful for people like myself, for Dr. Fines, and yes, we're in a new environment, different challenges that are good reasons for creating integrated residencies, but I'm certainly an advocate for believing that there is room for both pathways into becoming cardiothoracic surgeons.
Sure. And Dr. Fines, at your institution, you've actually gone solely to the integrated program, correct? And what was kind of the basis of that, and maybe you could share some of your thoughts into why you phased out your traditional program, or why you think other institutions are doing that and leaning more towards just the integrated.
Well, I think the first thing, of course, is that the number of residents as you graduate is regulated by the ACGME. So if you're going to graduate one resident a year, you have to figure out some mechanism to do that. For us, it made more sense to do it with the I-6, but this is probably the first time I've ever said this publicly, but I think that I agree with Dr. Wood 100%. What has happened over the last several years, when we started all of this, it was really my feeling that the I-6 should be the only way. Now, some of that was economics. And one of the things, you not only need a very strong relationship with general surgery, but you need the money to pick up several additional salaries to cover six years. But over the last 5-7 years, as the I-6s have come, and through the work of the Joint Council and the TSDA, I think we've better defined what educational process needs to occur in order to become a very good cardiothoracic surgeon. And I think the 4-3 and even the traditional and the I-6 have been able to tailor in such a way to understand what those needs are and to meet those needs. When we started with the I-6, a lot of the applicants wanted to do research. There wasn't a really good mechanism to do research. The 4-3 is an excellent. There are many institutions that, for one reason or another, general surgery will not significantly invest in the education of somebody who is not going to be board eligible in general surgery. So for them, that's very important. So I have to admit, I've come around. I think that as long as we keep the basic principles, and we have now aided by the fact that we are not only getting exceptional candidates on the I-6 side, but the candidates on the traditional side have gotten to be very, very good. So I think as long as we keep the basic principles and we're able to attract those people that can do it, multiple pathways seem to work.
Sure. And
so there you have
it. Dr. Shaw, being a trainee of the 4+3 program, maybe you can comment a little bit about your general surgery experience and whether or not you really feel like it sets you up for success when you got into the thoracic world, or if you feel that, you know, maybe there is some room for cutting out some of those rotations and, you know, allowing you to grow more on the thoracic side before getting in there.
Well, I definitely think the general surgery portion of my training has been important and has helped me become a better thoracic surgery resident. There are many things you learn in general surgery, from the basics of patient care, the basics of operative technique, ICU care. I think those were vitally important, but I believe the I-6 residents get that as well to some extent. There probably are some extraneous rotations throughout the course of the 5 years that could be cut down somewhat and replaced with you know, more innovative aspects of cardiothoracic surgery, whether it's cath lab stuff, interventional radiology sort of things, and interventional pulmonary sort of things. So I think those could be replaced, but I think the core rotations are very important to being a successful thoracic surgery resident.
And you know, I know myself being an integrated thoracic resident, people put a lot of emphasis on simulation. Dr. Fines, you do a lot of your research in that aspect of surgical education. Do you think simulation's here to stay, and how do you feel that it's going to contribute to thoracic surgical training for the future surgeons like myself?
Well, it's certainly here to stay. The boot camp and the various initiatives that have gone on have shown that. I think it's proven to be a very, very effective and educationally sound way of teaching a whole array of things, not only technical skills, but judgment, adverse events. We are partnering with the University of Washington and other centers on looking at exactly how it affects those things and how safe a surgeon is. So it definitely is there. Will it replace the operating room? Absolutely not. But it will enable trainees at all levels to get a comfort level and a skill level necessary so that when they're in the operating room, they are perfectly safe and they are able to assume graduated responsibility, and they're able to handle the very different types of things that can happen in the operating room. And cardiothoracic surgery has really been in the forefront of that with the support of boot camp and with the development of the simulators. We have the tools right now to produce sort of championship teams.
Sure.
So I think it's certainly.
And do you think that there's still a role for low fidelity simulators, things that we can make at the bench side and kind of do at home?
Absolutely. A lot of what we've been done is based on this concept of deliberate practice. The same basic principles that produce championship basketball teams and championship football. The practice and the repetition and coaching, all of that can now be applied much more readily, we've found, in the simulated environment.
Dr. Wood, you kind of alluded earlier on to the quality of the applicants that are applying for integrated programs, and you also mentioned that you guys have seen the application pool for the traditional programs have also gone back up here in the last couple of years. Can you comment a little bit about the characteristics that you've seen in terms of the applicants to the integrated program and how you think they compare to those traditional applicants?
I don't think it's fair to compare. It's like comparing applicants to college and applicants to medical school. They're at different stages of their education and career. And the good news is they're both great. The integrated applicants that we have, and I've just had them in Seattle and at my house, I mean, they're brilliant students. And it's easy to see how they're going to be great surgeons and great cardiothoracic surgeons. That's what's exciting to me, is it's the future of our specialty. And the hard part is how do you select from so many great individuals? But I have to say, the traditional residents, those that are in general surgery programs and have chosen to move into cardiothoracic, and sometimes it was always their plan, sometimes it's evolved out of during general surgery. Maybe they had an interest in surgical oncology, and then when they were doing thoracic surgery, they realized, rightly, that thoracic surgery is better than general surgical oncology. Or maybe they originally thought they were going to be a vascular surgeon and they had some time on cardiac surgery and realized correctly how great cardiac surgery is. So that's the way, that's a reason that it's still valuable to have individuals come in a traditional pathway like we still have at the University of Washington as well. I really like the diversity that produces within our own program and amongst the residents in both the traditional and integrated residency.
Sure. I know, me personally, I have friends that are in general surgery that they're concerned that these traditional programs won't be around when they apply, especially the younger general surgery residents. So I can probably speak on behalf of them that they appreciate programs like yours that have kept their traditional pathway and that foresee that still being around in the future.
I can guarantee that for the foreseeable future there will be the traditional pathways around for training cardiothoracic surgeons.
Great. Great. Well, in closing, do any of you have additional remarks or advice for potential applicants or even for program directors that might be watching this that are thinking they want to start a integrated program up? And you kind of alluded to how difficult it is, but maybe you or Dr. Fines can comment on that.
Well, I guess I'd say for people thinking about a career in cardiothoracic surgery, do it. It's great. There's nothing better than what we get to do in taking care of patients, in education, and in research. Being a cardiothoracic surgeon is a real privilege. For program directors thinking of moving into an integrated residency, I'd say do it if you're doing it because you think it's a good education paradigm for your institution and you have the support and resources to do it within general surgery and within the institution. Don't do it just to get the integrated applicants, because I think sometimes people like the idea of the great pool of integrated applicants, but I don't think that's the reason to have an integrated program. You have it because you've decided that's how you want to educate residents and you've developed the resources in the institution to do it and do it well.
Sure.
And I couldn't agree more. I think that's absolutely correct. I think if you're a program that wants, I think one of the things that has certainly come true is that you have to have a very strong relationship with general surgery. Unlike neurosurgery, neurology, and ENT, we are heavily based, both on the cardiac side and on the general thoracic side, in a good foundation of general surgery. And unless your program has a very good working relationship, and it goes both ways. You train them, they train you. Unless you do that, I don't think you ought to be in the I6 business.
Well, on behalf of CTSNet and myself, I want to personally thank each one of you for sitting on our panel today and offering your advice and your opinions on these various training paradigms. I know this is a hot topic always at the conferences, and I know a lot of the med students and residents that are out there that are watching this are going to appreciate it. Thank you.
That's great. Thanks, Mike.